are in listen-only mode.
Hello, welcome to the webinar. I'm experiencing a little bit of difficulties with my computer right now, so please bear with me a moment. So welcome to the webinar. Thanks for being here today. We are happy to have Dr. Carolyn Rutter, and she's gonna be sharing her expertise today with us, and she's going to go over the You Are the Key to HPV Cancer Prevention. Thanks for being here. My name is Carmen Boone. I'm an education coordinator from Oregon Pacific Area Health Education Center. We are a hosted agency of Samaritan Lebanon Community Hospitals, and our mission is to provide information and trainings to rural and underserved communities and get healthcare out there. Today, I will be your host and moderator. Now let's go over some of our housekeeping items. You are going to see on your GoToWebinar control panel that all microphones are muted and they'll remain muted during this session. If you're experiencing audio difficulties, make sure your computer speaker volume is turned up or use the phone option to listen in. Slides can be downloaded from the handouts menu. If you have any trouble downloading them, send us an email and we'll send you the slides. Please use the questions menu to type any question or comment at any time. Questions will be answered at the end, and if we run out of time, we would still answer your question via email. This webinar is being recorded and will be available on our website in about a week. Finally, if you have any questions, please email me at carmenb@samhealth.org, and I'll be happy to help you. Now, to obtain CME or CEU credit for this activity, you must log into www.eeds.com and enter this activity code. I'll repeat this information at the end, so you don't have to worry. You'll get it, and if not, send me an email. Please remember to claim your certificate within a week. The code expires in 7 days. This presentation is jointly provided by the National AHEG Organization, the American Cancer Society, Samaritan Health Services, and the Oregon Pacific Area Health Education Center. Dr. Rutter and the planners of this activity report that we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the content of this presentation. And this webinar is presented by Dr. Carolyn Rutter. She's a practicing radiation oncologist in Great Falls, Montana, with benefits Latent Cancer Institute. She treats many of the cancers known to be caused by the HPV virus and volunteers as an American Cancer Society HPV provider champion. Now, I'm gonna change presenters, and without further ado, I will leave you with Dr. Rutter, and let's start the webinar.
Well, thank you so much for the introduction, Carmen, and thank you everyone for joining us today. As Carmen mentioned, my name is Carolyn Rutter, and I'm a radiation oncologist with benefits in Great Falls, Montana. And I am just delighted to get to share this with you all. This is a subject, HPV vaccination and prevention, is something that's very dear to our hearts in oncology, where we treat these cancers all the time. And I love getting this opportunity to speak with, especially those of you who are on the front lines actually delivering these vaccines. We don't get to connect very much professionally. And this is my chance to thank you for the important work that you're doing. You're preventing disease and hardship for your patients that could occur decades in the future. And so it's, I think, sometimes hard to appreciate what that really means. And so my goal is to give you a little bit of a window into what these diseases and their treatment are like for patients, and in that way encourage you and also equip you to be able to give the vaccine as effectively as possible, because you're making such an enormous difference that way. So as Carmen already mentioned, we're presenting this jointly, and much of this information, most of it really was supplied to me by the CDC and AHEC, and it's a very nice selection of resources here that we'll get to go through together. So again, I have nothing to disclose, and here are our objectives. We're going to talk about why HPV vaccination is important for cancer prevention, and then talk about details about how the vaccine can be given, identify the right schedule based on patient age, talk about recommendations, and then just hopefully offer you some tools for how to effectively deliver a recommendation for these vaccinations and address parent concerns and patient concerns about things like safety, efficacy, et cetera. And then this also meets some criteria necessary for our pharmacy colleagues who are getting CME here. So let's see, I'm going to go to the next screen. There we go. So HPV, understanding the burden, HPV infection and disease. As you guys already know, there are many, many different strains of HPV virus, and about 80 types are responsible for the cutaneous infections that cause the common hand and foot warts. About 40 types cause mucosal sites of infection, and those can be the low-risk strains like 6 and 11, most commonly, that don't cause cancers but cause genital warts, laryngeal papillomas, and some low-grade cervical disease. The main high-risk types that lead to cancers are 16 and 18, but as we'll discuss in a bit, and as you guys know, there are many other strains as well that also do that. And the cancers we're primarily concerned with are cervix, anogenital, oral pharyngeal, and then some of these in situ neoplasms, low-grade cervical disease, and other precursors. So HPV infection, we know that these viruses and their many strains are becoming more and more common, and most men and women will be infected with at least one type of mucosal HPV at some point in their lives. And those infections may clear. Most people never know they have the infection, but of course, as you guys all know, the problem is that the viral DNA gets incorporated in the host DNA and can become oncogenic many years later. So the CDC updates this data for us. It's still a little bit in the rear, you can see, but here are the incidence rates for the block of time 2020 to 2016. And to me, what's really important about this is that the rates of oropharynx cancer now outnumber cervix cancer. So a common misconception that I hear as a mom of young children, you know, my kids are in the age group that needs this vaccine, and a lot of folks, I think, see this as a vaccine to prevent cervix cancer in women and don't understand the importance of oropharynx cancer, and that predominantly, as you can see here, affects males over females. But then, of course, many other cancers are very important as well. Anal cancer at 6,200 per year is a very significant issue. And rates are increasing. We've been able to see this in a few different studies. There was a Vermont study I've quoted here where they were able to show that the rate of HPV-related oropharynx cancer in males was increasing by a relative 5% annually, but that meant a doubling of incidence over a 10-year period. And then there was a SEER U.S. Cancer Registry study looking at the annual percentage change in rates of both oropharynx and anal cancer. That APC is something that describes the percent increase in the rate year over year. So that was between 2 and 3 for oropharynx cancer. Depending on the patient age, you can see that those predominantly occur between kind of mid-40s and patients' 60s. And for anal cancer, that number was 4.4. This is a pretty dramatic rate of increase. Who knows if that trend would continue or not? And I know it's statistics abuse, but if you start looking at the current annual rates and calculating that sort of increase over the next 4 to 6 decades, when the kiddos you guys are vaccinating now would be at risk for these cancers, you end up with these cancers rivaling like prostate and breast cancer in their incidence. That's probably not an accurate prediction, and thank heaven we have the virus. But it's, certainly since I was a resident, this has become an increasing problem for us, and I think arguably something like an epidemic since it's viral related. So again, HPV is tied to most of these cancers in these different categories, and the strains that are causing the cancers, the majority of them are covered by the current 9-valent vaccine. So I wanted to talk a little bit about why field treatment is so important. So treatment outcomes are largely good, but not uniformly good. For cervix cancer, many of you are out there doing pap smears, catching these early. Thank you so much, and addressing them with a great success rate. We see them in radiation oncology in particular when the patients don't come into you and they end up with locally advanced disease. And we are not nearly as successful. We lose a lot of patients to this disease. And once it's metastasized, we don't have a lot of good tools for keeping people around, and median survival is about a year. These oropharynx cancers that we're seeing more and more of, we tend to be very successful with treatment, at least in early stages. Again, the more advanced it is, the less successful we are. And I have lost patients, certainly, we all have, to HPV-related oropharynx cancer. Again, for cervical precancers, the incidence is very, very, very high. And as you all know, these can be successfully addressed, but it still requires some intervention. And treatment, of course, can have consequences. Early stage disease, you all have localized therapies like LEAP and cone, but some require a radical hysterectomy, and those can, of course, be morbid and costly and impact fertility. Locally advanced, as I was saying, we treat with chemo and radiation. Once the disease has gotten past the cervix itself, it can't be appropriately addressed with surgery. We treat it with chemo and radiation in a definitive fashion, and it's a big deal. It's 8 weeks of treatment, 5 weeks of external radiation, and then 5 internal treatments that are very involved, and then weekly chemo in addition. And in the short term, this is difficult for patients. They have a lot of GI and GU toxicity. But maybe what's even more important is the long-term sequelae. So obviously, all these patients are infertile. These ladies have issues with their vaginal health. Things are just scarred. There are issues with stenosis and sexuality. And then bowel and bladder damage can be a really big deal. Folks generally have bowels that are just not the same as before, fecal urgency, and sometimes fecal incontinence. And then there can be other issues as well, like proctitis with rectal bleeding, strictures, fistulas. Fistulas can leave people needing an ostomy, or even if there's a fistula between bladder and vagina with permanent percutaneous nephrostomy tubes. So that's rare that patients have those kinds of severe consequences, but of course, when we see them, it's a big deal. And then anal cancer is similar to cervix cancer in that really any anal cancer we address primarily with chemotherapy and radiation. And the good news is that leaves most people continent, but it's very difficult treatment. 6 weeks of severe diarrhea, and then we cause a temporary mucositis that's extremely painful. All these patients pretty much need narcotics to make it through, and they heal. But then in the long run, a lot of people have GI issues that sometimes make it so that they need a colostomy even if they're disease-free, because as I sort of put it to them, their bottom is not their friend anymore. The issues of frequency become so severe that life is just not manageable, and they're happier with that strategy. And then they have some of the other issues that patients with cervical cancer see, with sexual issues, cystitis, proctitis, strictures, fistulas, low risk but possible. Oropharynx cancer, which again is really becoming the dominant problem. So these cancers were more successful than we were in the past. When I was in residency, most of the patients with these cancers were smokers and drinkers. They didn't do as well, but they also didn't live as long after treatment. They had, changes from tobacco that meant that other health issues came up in the future for them. The patients I'm seeing now and have seen for the last 15 years are living decades after their treatment. And so that's good news and bad news. The bad news is that they live to see the consequences. So the treatment itself, occasionally you can get away with some transoral microsurgery, but the oropharynx has a lot of rich lymphatics, and there's just too much propensity for microscopic disease to go to the cervical draining lymphatics and then just be left around in the oropharynx, where you can't do a big comprehensive surgery. So people end up needing post-op chemo and radiation, or just definitive chemo and radiation, which we do very commonly. It takes 7 weeks. Severe mucositis occurs with this, with a lot of pain with swallowing. All these people typically need narcotics and a feeding tube in order to make it through treatment. They have dry mouth, poor taste, and then also dermatitis that's painful on their neck as well. So we get them through, but it is a rough ride. And this is to give you a sense of what it is we need to do with the radiation. It's a little window into our world. So we map out on computer where the dose needs to go. And you get this sort of like a topographical map of where the dose went, with the different dose levels and different colors. So here you can see in the red, we've got the high dose going to, this patient has a left base of tongue tumor, and then some positive lymph nodes in both sides of the neck. But really comprehensively, all the way from the skull base down to the clavicles, are the draining lymphatics that could be harboring microscopic disease, and they need to be swept with a lower dose. So it's just a lot of critical real estate that gets exposed to radiation. And studies are in place to see if we can de-escalate therapy, but so far there's been limited success with that. We haven't been able to change the chemo out for a less intense chemo. We're looking if maybe we can safely drop doses, but we don't know if we can yet. So this is just still morbid treatment. So again, the long-term sequelae are what can be heartbreaking, where you see these, young, healthy, fit, well-living patients 5 to 10 years out. And we, with broken hearts, sometimes call radiation the gift that keeps on giving. It causes a lot of small vessel ischemic damage, and then dries out salivary glands and other glands. And so it can be years and years later that you really see the gradual worsening of things like dental decay, trismus, trouble speaking, trouble swallowing, hearing loss, neck fibrosis, neck edema, low thyroid. And again, people will make it through great, and 3 or 4 years out look okay. And it's been alarming to see people come back then later with some worsening problems with these issues, and even folks who had to have a feeding. I met one woman who had to have a feeding tube put back in. And our more advanced techniques for targeting radiation help, but again, this is a decades-long potential threat. So the good news is you guys have a tool to actually prevent this from even happening, which is what we're here to talk about, the HPV vaccine. So what is the vaccine? It is a recombinant L1 capsid. We've all been thinking about vaccines, of course, a lot this year. This is made of proteins that form a virus-like particle, but it is non-infectious, and it is very effective at producing high levels of antibody titers, higher than one would get from a natural infection. So we currently have the 9-valent known as Gardasil vaccine that covers all of these strains. So the recommendation, as you guys probably already know, recommendation from the CDC is that we routinely vaccinate kiddos at age 11 or 12. And the vaccine series can be started as early as 9 years old. And if kids get this vaccine before age 15, they only need 2 doses, 6 to 12 months apart. And why so early? Well, we know that the immune response is more effective when we give this as an earlier age, and we've got a lot of evidence now to prove that 9 to 10-year-olds develop the highest titers. Their titers are 33 to 45% higher than kids who are vaccinated at age 13 to 14, and 3 to 4-fold higher if they're vaccinated after age 15. And then we're starting to see data about, of course, the outcomes we really care about, in actual infections and precancers. Australia's been doing this for a long time, as you guys may know, and even made this vaccine mandatory in 2007, I believe it was. And so they've been able to give us a lot of data, and they have shown that if we start this vaccine before age 15, you get a 75% reduction in HPV precancer neoplasms, as opposed to only a 35% reduction for age 15 or older at time of vaccination. But it's not too late to catch up after age 15, and we can catch up through age 26. And this is an interesting question: is what about age 26 to 45? Vaccine is approved up to age 45 by some bodies, not necessarily covered by insurance. And the question is, how helpful would that necessarily be? You know, at that point, exposure is probably already occurred, and the chance to really make a difference in cancer risk is probably gone. But if patients ask, that might be something they want to consider. So again, dosing schedules. Starting the vaccine before the 15th birthday, the recommendation is 2 doses, and that the second one be 6 to 12 after the first. We want at least 5 months between the first and the second. And if kids are starting at their 15th birthday or later, they need 3 shots total. The first one, 1 to 2 months after the first, and then the third one, 6 months after the first. And the minimum interval in the 3-dose schedule for the third between dose 1 and dose 3 is 5 months. So safety, this question, of course, comes up a lot. And there are lots of different bodies that are monitoring the safety of vaccines in the U.S., and the HPV vaccine is included in those. So many different databases looking for and monitoring and recording any kind of issues with early or late side effects. Again, these are the names of all of these different safety monitoring activities that are going on, including the manufacturer itself having a post-marketing commitment of 2 10-year studies to assess long-term safety. So at this point, we have, I think one of these later slides is going to tell us in a little bit more detail. We have data, about 12 years of data showing us that this vaccine is safe, but monitoring continues. So what we're interested in are early outcomes, mid outcomes, and late outcomes. So the early outcomes we can look for in years. We can study things like HPV prevalence and the prevalence of genital warts. Mid outcomes are going to take longer to be able to see an impact on, but those would be the precancers and in situ neoplasias. The late outcomes that we care about the most, the actual invasive cancers, we're going to have to wait decades in order to see an impact. And so the inference we are making is that by changing incidence of the HPV infection and prevalence, hopefully we're decreasing cancer rates. So in terms of looking at those outcomes, we have data now from Western countries that have been vaccinating in Europe, the US, and Australia, looking at prevalence, genital warts, and then cervical lesions. And in the US in particular, we are seeing declines in the vaccine type prevalence prevalence of the vaccine, the strains that are covered by the vaccine. We're seeing declines in genital warts, and we're seeing declines in cervical precancers. So this NHANES data is one example of some evidence we have that HPV incidence is declining with vaccines. So this shows that girls vaccinated or who are tested for HPV strains and grew up during the vaccine era versus before the vaccine era. The girls growing up in the vaccine era had a 56% decrease in being positive for these strains. And as time continues, that trend continues. And in Australia, we've been able to see a significant decrease in genital warts for both females and males starting in 2007 when this vaccine became required. And how long is protection? So far, there isn't evidence of waning protection. We only have data out for 10 years. And so we'll need to wait to find out if further boosters are needed after 10 years. So again, this vaccine is safe. We have about 12 years of data now showing no significant risk. And we can tell that it works, at least for the surrogates that we have, for the outcomes that matter most to us. And so far, this lasts at least 10 years, and we don't yet see any evidence of waning protection. So some potential tools to offer that might be useful in helping frame this conversation with the preteen or their parents. What we also can see from studies is that we have some potential to improve our rates of HPV vaccination. And one way to look at that is by comparing kids who got other vaccines that are due around age 11 or 12 with those who actually got at least one dose of HPV. And that's what we see here, is that there's a far higher percentage of kiddos who end up vaccinated for Tdap and meningococcus than get vaccinated for HPV. And again, if we consider that a missed opportunity when the kiddo was in the office, I know it's hard to get kids at this age to even come in for their routine well-child checks, but they were there, they got their other vaccines, but didn't necessarily get the HPV vaccine. This would be evidence to confirm that there is a gap. And I think it's interesting to see that in rural communities, this seems to be something we struggle with more. I'm not sure why, but for meningococcal vaccine, and for example, so I think vaccines in general, but also the HPV vaccine, the rates are highest in urban populations and lower as you get more rural. And this is another example of some data showing a gap between rates of vaccination in urban versus rural settings. And again, what we'd like to convince you is an important strategy is simply making a strong recommendation for this vaccine. And this study showed that in rural communities, we might not be making that recommendation as clearly and strongly as we potentially could. And let's see, this slide didn't come. Oh, so again, if the vaccine is recommended, there are some studies that show us that the rates of the child actually walking away with the vaccine are higher than if it's not brought up. And so in this study, kiddos who had received, there was about 78% of kiddos and their parents had received a clear recommendation for the vaccine. And of those who got the recommendation, 75% received the vaccine. Of those who didn't get described having been given a recommendation, only 47% walked away with the vaccine. And so in this study, the investigators were looking at top reasons why the vaccine series wasn't started. And parents very commonly reported that it hadn't been recommended, among other things, but that's the one that we perhaps have the most control over and opportunity to change. So there are some studies showing that a strong provider recommendation does correlate with vaccination rates, not just in girls, but in boys. The study came from the Journal of Pediatrics and again showed that a strong provider recommendation was one of the most significant factors predicting vaccination rates. So another thing that's interesting here is that we might underestimate how much parents actually value this vaccine. And so this data shows that at least in one group of polled parents, they value the HPV vaccine just as much as meningitis, hepatitis, pertussis, other vaccines that we commonly administer. And then in what they further looked at is what was the clinician's estimate of the parents' value of those vaccines. And we as clinicians kind of appropriately predicted the value parents place on common vaccines, but we underestimated, at least this group of clinicians underestimated the value that parents placed on the HPV vaccine. So there might be a disconnect between what we perceive to be parents' values and concerns, and that might be an opportunity again. So here the CDC is offering some, going to start offering some different ways to, sort of scripting as tools to just to consider if they would fit into one's practice. So what is an effective recommendation? One strategy that they recommend is to just bundle this recommendation with the meningococcal and tetanus vaccine recommendation and recommend them the same way on the same day. And so, and just, do it in one big sentence, basically. So your preteen needs 3 vaccines today. It's going to protect them against meningitis, HPV cancers, and pertussis. And they kind of like the idea of sandwiching the HPV vaccine in the middle of those two. You could consider that a little sneaky. I think it's sneaky with good intention. So again, bundling them together. So here's another idea of some scripting, maybe with a little more detail about we're going to be protecting your kiddo from the infections that cause meningitis, HPV cancers, and pertussis, and we'll give them to you today. This gives an example of some scripting with a little bit more detail that, meningitis is rare but dangerous. Second vaccine prevents HPV infection, causes several kinds of cancer, and then the third one is the tetanus booster and protects against pertussis. And you'll see in all of these quotes, they end with, and we can give it to you right now. And then, of course, some parents need some reassurance. Many, as you guys know, will just go ahead and get the vaccine. Some need to hear that we as clinicians really believe in this vaccine and think it's meaningful. And of course, you guys would always be communicating with parents about kind of what the root of their concerns are. Some questions that CDC knows might come up would be, why do they need the vaccine? It's going to prevent cancer. What cancers are caused by the infection? I would actually suggest that we put throat first because it doesn't have any strange connotations or, sticky connotations. And it really is the cancer that is now the biggest problem. Is my child really at risk? And so, we think the answer is yes, because it's just such a common virus. And getting into this a little bit, this quickly spins into my kiddo's not sexually active. They're not going to become sexually active anytime real soon. Why should I be worried about this now? A few slides coming up will address that a little bit more. It's, I think, nice to remind people just how common this virus is, that it's pretty much everywhere, and sort of look at it that way potentially instead of focusing on the sexual connection. Why at age 11 or 12 years old? As you know, the answer is because it produces better immunity. and is more effective at those younger ages. And also, it means you only need 2 shots instead of 3. So again, they bring up some examples of other things that we do preventatively, and we do them early, like putting on a bike helmet or putting on a seat belt. The idea is not to do it at the last minute, and certainly not to miss the opportunity. So just, again, some scripting about how to engage with them and really align with the parent in their goals. And then this question often comes up, kind of like we were talking about, is this sort of telling my child that I am expecting that they're going to become sexually active, and is it going to actually encourage them to go into that new phase of life? Actually, it's been studied extensively, and no study has been specifically looking at this question: does getting the HPV vaccine increase a young person's likelihood of becoming sexually active, or decrease the age at which they become sexually active? And the answer is consistently no. But it is another reason why it's nice, I think, to start it as an early age, because it doesn't even come up. When I took my 9-year-old in, I just told her, you're getting a shot for cancer. She said, does it hurt? I said, it hurts less than cancer, and that was kind of the end of the story. So I know you have more experience than me with this, actually making these recommendations. So maybe we'll get some time to share some of those experiences in the end even. How long can you wait and still give just 2 doses? Again, as long as you get the first dose before the 15th birthday, you only need 2. But how about let's just get it done? I'm concerned about the safety, and I've read things online. I don't know how much this is an issue in Montana. I've just recently been able to start practicing here, but came from the Pacific Northwest, where there's a lot of people with kind of a lot of chatter and buzz about concerns about vaccines. And here, again, they talk about partnering with the parents in terms of the shared goals for what's in the best interest of the child, and emphasizing that there are now lots of studies showing how safe this vaccine is. They can cause, we know from those studies that there can be pain, swelling, or redness, possibly a headache, and really that's it. Can it cause fertility problems? There is 0 evidence of that in any of the studies conducted so far, but we absolutely know that for girls in particular, of course, cervix cancer or precancerous lesions can definitely impact fertility. How do we know if it works? We've gone over that data. This is sort of how that could be encapsulated for parents and kids, that we have studies continuing to show that it is preventing HPV infections, genital warts, and precancers. And some primary care providers have told me that they have a photo of genital warts that they show the young person in their office, and that's very effective for that child advocating for themselves to have the vaccine. Why do boys need to be vaccinated? Again, because of this risk of oropharynx cancer, the increasing problem that it is, and the very significant health issue that it is for the men who eventually have to deal with that disease. So now's the time to prevent it. We only want the vaccines needed for school. And so again, just reflecting with the family that the school entry requirements don't necessarily actually fit with what's best for the child. And so that's why we as providers are recommending this vaccine. Would we give it to our own kids? I hope your answer to that is yes, if you're a parent. And when do we need to come back? And so we talked about how to set up that vaccination schedule to get the boosters. And again, how it's different for children of varying ages. Is 2 shots enough? Yep. And in fact, 2 shots before age 15 is better than 3 shots after age 15. And so again, just that hope that even if parents say no, a seed might be planted that later on they, or even the child themselves later on, decides to go ahead and get the vaccine. So what about if I'm in between the ages of 27 and 45? And again, that's where it might not be as effective as it would otherwise have been, and it might also be something that insurance doesn't cover, but it is still an option for folks. So the CDC gives us lots of additional resources to help with this project. They have videos online for some scripting and ideas, tools, and tricks. And then they also have a lot of written materials to help offices and programs and healthcare systems attack this project. So aligning with communication and these goals with everyone in the department can be important, really helping the staff who is delivering these vaccines to understand the things that we've just discussed in terms of how safe the vaccine is and why to give it early and why it's effective and why it's important for boys and girls, so that patients and their families are getting a consistent message. And then there are, again, more CDC produced materials available to help with these projects, and in healthcare systems and large and small clinics, having processes in place, as you may already have, to make sure that anytime a child comes in, their immunization status has been checked. There are standing orders in place, so it's very easy for staff to just deliver the vaccine. Reminders in place, cues, and things like that, so that every opportunity is taken advantage of. And so another way to strategy for a quality improvement project of this nature, the IQIP can give us access to our vaccination rates, and watching those and having some benchmarks to compare to. I know most of us are kind of metrics and performance driven, and so when we're just simply measuring it, we all know is something that can improve quality because it increases our own awareness of what our success rates actually are. But bottom line is, you guys are really making a huge difference here. So thank you for all that you're doing. Thank you for listening today. I hope that some pieces of this in some way are useful tools to you in your endeavors, because it's what you're preventing is, I think it's clear. I feel it's a really big deal and really meaningful in these kids' lives. So thank you. And yeah, that's the end of my slides, but I'd love to hear if there are any questions.
Thank you so much, Dr. Rutter. So let's give our audience a couple of minutes while they type their questions. Remember, under the questions drop-down menu, I'll go over what we need to remember. So let's see, things to keep in mind. You will receive an email 1 hour after this webinar. It will contain instructions on how to obtain your CME or your CEU credit, and it's also going to include a survey link. To help the CDC-funded NAO HPV project, please take a moment to complete the survey. We will really, really appreciate it. If for any reason you need a copy of the slides and the handouts, please send us an email and we'll send you the file. The webinar is being recorded and it will be available within a week on our website. You can see it there circled. Feel free to reach out to me or our office if you have any questions or concerns. I'll be happy. We will be happy to be of assistance. To obtain your CME credit, log into www.eats.com. You'll need to enter the activity code and then complete a program evaluation. This is the activity code for today. Write it down, and remember, it expires in 7 days. So now let's see if we have questions or comments. I think our audience, I can only see comments that say thank you. Love the presentation, but I don't see any comments so far or questions.
Okay. Well, if anyone has questions or I can be of help, please feel free to reach out. I put my email address on that first slide, but it's Carrie, CARRIE .Rutter, RUTTER @gmail.com. And again, just thanks so much for joining us, and thanks for what you do.
Thank you so much, Dr. Rutter. We just are getting more thank yous and more people that confirming that they received this webinar and it was great for them. Thanks the ones that are sending the comments. And so once more, write down the activity code. And well, thanks to our speaker. Thank you so much, Dr. Rutter, for sharing your experiences and your knowledge with us. And thank you all for participating today. And now you have completed today's webinar and you may disconnect. Have a wonderful day.
Thanks, Carmen, for all your help.
Thank you. Bye-bye.